Hi guys, so this case study is on psoriasis. So the patient is a 55-year-old female. They present with large oval circular plaques over their scalp, trunk, elbows, and knees. This patient states that she had issues with sensitive skin in the past and has broken out in these types of skin rashes off and on for as long as she can remember, starting in college when she was in her 20s. The patient states the areas where the plaques are painful and itchy, and her elbows and knees have also been feeling very sore. So she is reporting itching, burning, and soreness to the areas of lesion, as well as bleeding at times, especially caused from the itchiness. She is also complaining of that itchiness as well as dryness to her scalp. She states her fingernails feel thicker and that she's having a difficult time completing her typical Pilates workouts and runs due to the stiffness and soreness she feels in her knees and her elbows. For her history, she states, as mentioned earlier, that she's broken out in rashes like this multiple times in the past, but that this time is the most severe. Um, she states that she remembers getting rashes intermittently like this since she was in college in her 20s. She states her mother also had sensitive skin and used to suffer from these rashes as well. She smokes 2 packs a day of cigarettes and has for the past 20 years. She was also recently in the hospital for hyperglycemia, in which she was diagnosed with type 2 diabetes. She was also started on a beta blocker for hypertension, as well as a statin for high cholesterol. Upon her physical exam, oval circular plaques that were evenly distributed over her elbows, knees, trunk, and scalp were found with silver white scales crusted over them. Upon removal of the scales, pinpoint bleeding was present, as well as red, salmon pink colored lesions lying underneath. Her fingernails appeared to be thicker with ridges. Based on all of this, including her history and her physical, the diagnosis is plaque psoriasis. The patient had prior exacerbations of similar rashes beginning in her 20s, and psoriasis typically first appears between 15 and 22 years old, and then is characterized by periods of exacerbations and remissions, with a second peak between the ages of 55 and 70. The patient's mother could have also had this disease from the patient's description, which would put her at risk as there's a much higher risk of developing plaque psoriasis if one individual already has the disorder in the family. Trauma is also known to trigger exacerbations. The patient was recently under physical and mental stress with a hospitalization and life-altering diagnosis. The patient was also recently started on a beta blocker as well as a statin, which are both drugs that can exacerbate psoriasis. Also, smoking is known as a trigger, and metabolic comorbidities are seen in association to psoriasis, including type 2 diabetes as well as hypertension. She presents on physical exam with classic psoriasis plaques symmetrically in distribution with silver white scaling crusted over, as well as pinpoint bleeding upon removal, known as Auspitz sign. Nails also appear to show signs of psoriasis with thickening as well as ridges. There is also a concern for psoriasis arthritis, as there is presence of stiff, sore pain in her joints. Diagnosis is typically based on clinical presentations. Psoriasis may need to be differentiated from tinea corpus, a fungal infection, or eczema. If plaques persist and are resistant to treatment, she may need to be tested for squamous cell carcinoma or Till cell lymphoma, and those would need to be excluded through histological examinations. A Woods lamp examination may also be utilized to rule out some fungal infections, as psoriasis does not fluoresce under ultraviolet light. Treatment is tailored based on age and how extensive or severe psoriasis is. It can include topical applications, phototherapy, systemic drugs, or other alternative therapies. For this patient, topical therapy will be considered first. This may include emollients, moisturizers, corticosteroids, Keratolic, vitamin D3 analogs, or calcineurin inhibitors. A combination of multiple of these topical agents may also be used. Light therapy could also be used in conjunction for this patient. If the patient is not responding to topical treatments alone, systemic drugs may need to be considered, including methotrexate or cyclosporin may also be used.